So when we are talking about the leg dominant, it's basically the pain changes with the pain. So you have to remember what pain is present with which kind of diagnosis. That's main important. So worse with flexion, then it's a disc pain. Worse with the extension, then it's a facet joint pain. If a pain change with the back movement, then it's a sciatica, or pain with an activity, then it's basically spinal stenosis. Then again, the treatment for all of them is same, like, doing the opposite activity, what is causing them pain, and then along with that, asking them to do the lumbar roll, medication, like, physiotherapy, all of those ones. That's, I think you can make a sense with that one, but that's not important. The important point is making the diagnosis, especially with the lower back pain. It's kind of difficult to understand if it's a facet joint one, if it's a sciatica one. So please, with the history, it can give you a lot of idea that what's going on. So please keep it in your head. Then this point here, if the history taking physical examination rule out the red flag, basically the quad equina part, and then the history of all this. So red flag is basically when is the patient to be sent to emergency. So if there is an quad equina syndromes, in those cases, you have to send them to emergency right away. If there is a severe worsening pain at night time, laying problem, then it's an urgent. If there is a trauma, then it's also an urgent. If there is a weight loss or cancer history, it's also an urgent, but not emergency. If there is a steroids and drug use, that's also an urgent. If there is a patient with a pain more than 50, 65, that's basically soon. Widespread neurological pain, it's basically soon. So only emergency is quad equina. And you know what is quad equina, like loss of sensation and all of that. Then the yellow flag is basically that pain is there and it's affecting their mood, daily life, not wanting to do stuff. So it's like that. They believe that the pain and activity are harmful, sickness, mood change, expectations problem, then the claim, and then back pain, time, awake, work, job, everything is messed up. This is all about yellow flag. Then if there is red flag, in that cases, you have to send the patient to emergency right away, and then they will do whatever the specialist and all of that. If it's not a red flag, please, the red flags are important. That's why I said whenever there is back pain, quad equina, after quad equina, we'll think, okay, now this is my case. So as a family physician, we always make sure that he does not have an emergency. But if someone is sitting down and telling you, oh, I feel like I am having this problem. Like I recently saw a patient, he's not having back pain, but he's having quad equina symptoms. Now that was not making any sense to me, but anyways, I asked him, does he recently pick up anything or any heavy activity? And he did an X-ray. X-ray was fine for his back pain, but he's having loss of sensation in his bladder and bowel. That's what his main complaint was. Since I was thinking of quad equina, so I referred that patient to emergency right away, or I ask them to see orthopedics. Like I refer them to the orthopedics right away. So in Manitoba, we do them like a different way. We don't put the referral. We just ask them to do a walk-in in that orthopedic clinic. So then the red flags is no. Then acute or subacute. In those cases, we do educate the patient. Then the self care in specificities, encourage the patient physiotherapy, acetaminophen, NSAIDs, opioids if very severe cases. Then in the chronic cases, usually they are up to that level where they're using opioids. Then along with that, acetaminophen, Voltra gel, TCA, cyclobenzaprine are very, very helpful. Then community-based activity programs, then giving them muscle relaxant, acupuncture, massage therapy, that's what they helpful. In the acute and subacute cases, after 1 to 6 months, we do refer them to chiropractor specialists. So, think of that one. If this is an acute or like a very short period of time, in that cases, we do try to avoid referring them to anyone. We try to give them painkillers, muscle relaxants, a gel, or whatever possible, TENS machine, what they can do by themselves. After 1 week, keep it in your head. After 1 week, then we, okay, go to massage, go to physio, go to whatever it is. Okay. Then comes the menopause or the hormonal therapy. So we already discussed these ones too. Like the hormonal therapy is one of the answers for everything. But if there is any possible choice for SSRIs, so in those cases we go for those ones. But again, calcium and vitamin D is one of the answers for the bone problem. So in menopause female, the thing that you have to um, discuss or rule out or whatever it is, the first line is osteoporosis, not mood, no hot flashes, No, nothing at all. Osteoporosis. Even though there is cardiovascular disease or whatever, but in menopause, the main problem is osteoporosis and giving them calcium and vitamin D. Okay. Then comes the osteoarthritis. Osteoarthritis could be there, like the joint narrowing and then friction is there, no laboratory investigation, nothing at all. Usually, if you still wanted to do the hallmark is X-ray, in that case, is then going for the goal physiotherapy education, letting them know that you'd have to do exercises to prevent it getting worse. Then PUD, HTN, high blood pressure, acetaminophen, NSAIDs, all of those ones. And the ultimate goal is giving steroid injections or the hyaluronic acid injections. Then when we are talking about osteoporosis, menopause, then when we do the osteoporosis, if it's of less, now the age factor for the osteoporosis is very important. If it's less than 50, there is a could be the problem is virility fractures, high risk mechanisms like the nutrition issues, hypogonadism, or malabsorption, or inflammatory like celiac and all of them. Keep that in your head. Hyperparathyroidism and then those ones. If 50 to 64, then virility fracture at 60. Then one important thing: glucocorticoids, steroid use can cause the osteoporosis. So if someone has Crohn disease, later on they can get osteoporosis because they might be on steroids. Then the hip fractures, then osteopenia, alcohol consumption could be there, smoking could be causing that, and low birth weight and all of that. In more than 65, it's very common. In the first thing, we start with BMD testing, like bone mineral density, assessment of the fracture if it's low risk. Benefit from the pharmacotherapy, assess the risk in 5 years. So pharmacotherapy is calcium, vitamin D, or whatever, the bisphosphonates and all those. Then comes the moderate risk, 10 years of the fracture. So in that cases, we are looking like how do you find this risk with the BMD? Then the lower thoracolumbar radiograph or the vertebral fracture assessment. Then the decision making by the identifying the vertebral fracture. If there is a high risk, and then we go for the fracture, and then doing the good evidence for the pharmacotherapy, like starting bisphosphonates or high dose, whatever those ones. When we are talking about the moderate risk, and we checked for their let what are we going to do further, like how you are going to manage that moderate risk, like because for the high risk we do whatever we want to do, for the low risk we want to educate or whatever. But with the moderate risk, sometimes we don't know what to do further. So in that cases we go for the x-ray or x-ray of the thoracolumbar, like the lower risk one, lower back one. So which one, T4 to L4, in that one, or the vertebral fracture assessment, checking that one, and decision making by identifying the fracture. What are you going to check for that one? Factors affecting make consideration of the pharmacological, like where are you going to give the medications? How do you check for that one? If there is a vertebral fracture, like compression fracture, backbone fracture, quadricuana syndromes, now this person is susceptible to get something. Previous wrist fracture. Wrist fracture is something that can give you an idea, okay, there could be osteoporosis going on. And the T score should be minus 2.5. The more less it is, the more better it is, but more minus it is high, the more bad it is. Then the lumbar T score is basically less than the femoral one. So lumbar should be more than the femoral one. Like the problem is basically in the backbone. We are talking about the backbone. So then there is a rapid bone loss, man undergoing the androgen activity. So androgens do causes osteoporosis, like calcium absorption. And then female going the aromatase inhibitors, long-term repeated glucocorticoids like steroid use. So you are thinking all of those ones which are affecting the calcium absorption. These are the factors where we have to start the treatment. Then the recurrence fracture and the other disorders like osteoporosis could be there. So with moderate risk, if there is a underlying pathology going on which affects the bone, for your easy understanding, in those cases we do the BMD again in 1 to 3 years and assessment of the risk, and then start the pharmacological treatment. Simple. This is something that you need to keep in your head. What do you do first? BMD. After that, you do an X-ray of the lumbothoracic. What are you going to do if there is a T score of 2.5 or minus 2.5? I saw one of the question in MCC practice test where they give the T score and ask you what to do further. So in that case, the answer was repeat BMD in 1 to 3 years because the T score was good. Okay. All of these things is same written over there. I think we did discuss the STIs. Same thing over there. Like contacting the public health is most important. Then again the urethritis, gonococcal, and then chlamydia one, then HPV, and then herpes simplex and syphilis one. In these cases, we do tell the one. And then keep it in your head that when we are talking about the penicillin, which one, benzathine penicillin, aqueous penicillin, IV, IM, whatever it is, or it's the oral one. For simplex, it's an oral one. For syphilis, it's IV. Sorry, not IV, IM. Then for the gonococcal, it's oral. Then the sinusitis, it's the same like upper respiratory tract infection. So with symptoms of PODS, you have to keep in your head. Then again, please, whenever you are reading the anything, keep reading the red flags. How do you go for the symptoms of sinusitis? If it's a recommend FABs, referred for the, like if it's a high swear one, then in those cases we do send them ENT referral. But if it's more than 7 days, likelihood of the bacterial infection starting with antibiotics. If it's less than 7 days, it's viral and it do get treated better. If it does not, then we go for antibacterial. For diagnosis of the antibacterial, bacterial one, nasal obstruction could be there, or any of the facial pain, obstruction, prolapse, or smell. So usually, you get an idea that what's going on. If it's a bacterial one, then fever, obstruction, discharge is coming, the smell is affected, and worsening after 5 to 7 days, and worsen more than 7 days. So in that case, is mild to moderate. We do give them steroid. And if it's a severe one, in those cases, we give them inhaled corticosteroids, which is basically Symbicort, and then the antibiotics along with that. So response in 72 hours, basically continue that one. And if not, then you have to add the other antibiotics with steroids. In this one, if it's a severe one, we already give the steroids and antibiotics. And then if it's good, then continue. If not, then change the antibiotics and then check again. So you can see every 3 days, we are keep on checking it again and again. In sleep disorder, there is one thing here that the obstructive apnea causes high blood pressure. I don't know if it's written in this chapter or it's written in somewhere else. Anyways, it causes high blood pressure, 3 times higher than other people. So that why we have to treat the obstructive sleep apnea. So please, this one here. Usually we do said, okay, we do, sleep studies, all of that one, but complete sleep diary every morning for 1 to 2 weeks. That's how you start approaching a sleep obstructive case. The answer is sleep diary. We do sleep study, but sleep diary is different. So in that case, it's like how we see the patient. So a patient comes to you, be like, okay, I feel more tired in the morning time. I feel like I'm not sleeping enough, or insomnia, or whatever it is. So we ask them to complete a sleep diary and then record bedtime, sleep latency, total sleep time, so all of those ones. Then after that, we start sleep study, refer for sleep study, nocturnal one, daytime, whatever the sleep latency. Primary insomnia, in that cases, we have to check for anxiety, bedtime, all of those issues, and then giving them medication according to that one. Or sleep hygiene, discussing that sleep hygiene. Like, so you can see what are the first line is basically sleep hygiene, relaxation, stimulus control one, like avoiding phone, whatever, and sleep restriction, and then inappropriate belief. Then pharmacological treatments like giving trazodone, lorazepam, zopiclone, zolpidem, all of those ones. Then comes snoring. In the snoring part, you have to keep it in your head that it could be with the polyps or any obstruction that's going on there. Then in those cases, we have to do CT scan or MRI. Then again, sleep on the side, nasal dilators could be used. Obstructive sleep apnea, we give the CPAP and BiPAP. Obstructive sleep apnea, the treatment is with that one, and then the diagnosis is based on the nocturnal polysomnography. So we do, the first line is not first line. The next step is sleep diary. The first line is sleep study. Then the diagnosis is nocturnal polysomnography. The words are different. Daytime somnolence or the non-reactive sleep, and then poor sleep, and very tired. So you can see here, this is the word I was talking about. It causes 2 times high blood pressure, 3 times heart attack, and 4 times stroke chances. That's why obstructive sleep apnea causes higher chances of stroke. Please keep it in your head. It can be asked that obstructive sleep apnea causes what? So it causes stroke. Obstructive sleep apnea causes 3 times more heart disease. Obstructive sleep apnea causes 2 times more high blood pressure. Then again, we have to check the modified factors like supine, avoid supine, weight loss, alcohol, sedatives, and then smoking, opioid use. And then we are going for the treatment with the CPAP, BiPAP, and then later on is the surgery. Hardly somebody go for surgery and then report to the Ministry of Transport if they have CPAP. So usually we do test that one. Then the sore throat. Sore throat is mainly the streptococcal one or the viral one. Mainly, with the whatever is going on, you get an idea if it's if it's environmental or if it's the bacterial or viral. Then the clinical presentation is viral. Pharyngitis, EBV, Coxsackie virus, herpes simplex, this just resolve by itself. When it comes to bacteria, you just need to remember when are you going to do the test for the GABS. So here are the points, the mentor ones, this one. So if there is no cough, history of fever, tonsillar exudates, swollen, age 5 to 14. And if there's a middle age, like young people, in that case, it's 0. And then more than 45, it's -1. So if there is score of 0 to 2, in that case is no further treatment needed, like there is no cough, little bit fever, in that case we don't need to do anything. But if there is cough, now fever is there, tonsillar exudates are there, you feel like lymph nodes are swollen, many people does not present with this lymph node, but yeah, and it's more common in the children's. Okay, so in that cases you do rapid test is something that we do in clinic right away, and in that cases you can start the antibiotics right away. Okay, even if the rapid test is negative and the patient is less than 20, we do throat culture and sensitivity. And after that, we can start the antibiotics, or you can start the antibiotics after that. Then that's how you can do that one. Please keep it in your head, the M Centaur one. This can be asked in that one. There is some, scoring for the pneumonia. There's some scoring for the throat one, this GABS. And there is another scoring for pulmonary embolism. Yeah, please read those ones. Then the viral pharyngitis, antibiotics not indicated, systematic treatment, then GABS. In that case, you have to give antibiotics and get antibiotics for 10 days. So it can cause glomerulonephritis, rheumatic fever. So you have to watch out. Even though you start the medications, it's not going to decrease the effect of the glomerulonephritis. If someone is susceptible to get that one, they will get it. Then the routine follow-up is not required for the patient. Like after giving antibiotics, you don't need to follow up with the culture and sensitivity. Then Epstein-Barr virus, in that cases, we do check for the hyperspleen. Usually we don't go for any testing, but yeah, if someone wants to go for that one, then we do the monospot test. So then we do give the acetaminophen and ask them to avoid playing for at least 1 month. Avoid contact, or sorry, avoid contact sports for at least 1 month. This 1 month is important. Sometimes they do ask for how many periods you will give them the restriction. Okay, so I thought it was 1 week until I find it out this is 1 month. Splenomegaly and then air obstruction, corticosteroids can be given. Then there's palliative. So I think we are done with the family medicine today. We will start with the epidemiology because I could not find my notes. I would have started it today. So I wanted to start it today. No, no.